Welcome to this explainer. Today we're looking at something that's honestly pretty alarming, and it's hiding right in plain sight. Every single year, thousands of patients develop acute kidney injury. But here is the truly shocking part. It's not from some rare exotic toxin. It's actually caused by a combination of three totally common medications that are entirely safe on their own. In fact, I'd bet you probably have at least one, if not all of them, sitting in your medicine cabinet right now. But when they're combined, these three routine drugs create a literal perfect storm that can destroy a kidney. So what's the big mystery we're unpacking today? How on earth does a basic over-the-counter painkiller, a standard blood pressure pill, and a routine diuretic team up to create a massive medical crisis? Individually, we all know they're absolute cornerstones of modern medicine, but together, they trigger what medical professionals ominously call the triple whammy. Okay, let's dive right into this and figure out exactly how this happens. Here's our quick roadmap for today's explainer. We'll cover 1. The perfect storm, 2. Inside the kidney's plumbing, 3. The 3 drug culprits, 4. Recognizing the danger signs, 5. Treatment and prevention tactics, and 6. High-yield exam takeaways. Let's kick things off with Section 1, the perfect storm, a hidden medical crisis. Moving right along to Section 2, inside the kidney's plumbing and the nephron's delicate balance. Think of the human kidney like a masterfully engineered filtration plant. It doesn't just passively sit there receiving blood. It actively and fiercely regulates its own blood flow to maintain this incredibly delicate, perfect balance. The ultimate metric of this balance is GFR, or glomerular filtration rate. Simply put, this is the vital rate at which your kidney filters the waste out of your blood, and your body defends this metric like crazy. If overall blood pressure drops, say you're super dehydrated, the kidney doesn't just give up, it physically adjusts the tone of its incoming and outgoing blood vessels. Those are the afferent and efferent arterioles. It tweaks them to keep that filtration pressure exactly where it needs to be. There are two beautifully opposed biological forces doing all this heavy lifting. On one side, we have prostaglandins. These guys are produced locally, right there in the kidney, and they act to dilate, or open up, the afferent arteriole. Think of this as cranking open the inflow valve to let a rush of blood into the filter. On the exact opposite side, we have angiotensin 2. This hormone does the reverse. It constricts the efferent arteriole, pinching the outflow valve shut. So by opening the inflow and pinching the outflow, pressure builds up perfectly inside the glomerulus. It keeps filtration going even when your overall bodily blood volume is running low. It's an incredibly elegant defense mechanism, isn't it? All right, Section 3, the 3 drug culprits, dismantling the defenses. So what happens when our everyday go-to medications systematically wreck this elegant defense mechanism? Well, let's break down the exact core of the triple whammy. First up, we have NSAIDs, your standard ibuprofen, naproxen, diclofenac. They work by blocking COX enzymes, which basically halts prostaglandin synthesis. Remember those prostaglandins opening the inflow valve? Without them, the afferent arteriole constricts. Boom, the inflow is choked off. Next, we have ACE inhibitors or ARBs, super common blood pressure meds like lisinopril or losartan. They block angiotensin 2. Remember how angiotensin 2 pinches the outflow valve to keep pressure high? Without it, the afferent arteriole just dilates wide open and all that pressure escapes. Finally, we have diuretics, water pills like furosemide. They reduce your circulating blood volume entirely, which drops the overall pressure the kidney even has to work with in the first place. Now, individually, a healthy kidney can easily compensate for just one of those drugs. But when you combine all three at the exact same time, total system failure. The inflow is choked, the outflow is blown wide open, and the overall fluid volume is totally depleted. Glomerular pressure completely collapses. GFR plummets. This is exactly what causes pre-renal acute kidney injury. And the truly terrifying part? This whole cascade can kick off within mere days of a patient taking that third drug. Which brings us to Section 4, recognizing the danger signs. Who is really at risk here? Zooming back out from the microscopic plumbing for a second, we know that not everyone taking these 3 meds instantly goes into kidney failure. But certain compounding factors make some patients exceptionally vulnerable. Older adults, for instance, naturally have a reduced renal reserve just from getting older. Patients with pre-existing chronic kidney disease, or CKD, already have fewer functional nephrons to help compensate. Add in some dehydration or an acute illness, like a nasty bout of vomiting or diarrhea, and you seriously compound the fluid loss from those diuretics. Finally, short-term high-dose NSAID use, like a patient who pops a bunch of prescription-strength ibuprofen after tweaking their back, is very often the match that lights the powder keg. Here's the really scary part. Early signs of this crisis are incredibly dangerously subtle. We are talking about maybe mildly decreased urine output, a little bit of fatigue, or some unexplained nausea. There is no giant flashing red light that screams kidney failure. Because the presentation is just so nonspecific early on, taking a thorough probing medication history is absolutely critical. You literally have to ask, hey, did you recently start taking anything for pain?
If you do run labs, there is a stark, glaring red flag you need to look out for. A BUN to creatinine ratio climbing above 20:1. This specific ratio strongly indicates a pre-renal pattern. It confirms that the kidney is being starved of blood flow and pressure. If you see this in a patient who's already on blood pressure meds and just tweak their knee, the alarm bells need to be ringing loudly.
Section 5, Treatment and Prevention Tactics. Stopping the cascade.
So what's the game plan when we actually spot this happening? How do we stop this dangerous domino effect? The good news is, if it's caught in time, the kidney can usually recover. The clinical protocol is really clear. Step 1, discontinue the NSAID immediately. That's usually the sudden reversible trigger that tipped the scales in the first place. Step 2, reassess the patient's volume status. You're probably going to need to hold the diuretic temporarily until the kidney regains its footing. Step 3, monitor renal function closely, particularly creatinine and potassium. Why? Because ACE inhibitors already predispose folks to hyperkalemia, and a dropping GFR is only going to make that worse. But you know what they say, right? Prevention is far more effective than treatment. And that brings us to a massive takeaway. Counsel patients to avoid routine NSAIDs and reach for acetaminophen instead. This is huge. Patients on an ACE inhibitor and a diuretic are already taking these as standard chronic therapies. The variable we can easily control? The painkiller. Swapping out NSAIDs for acetaminophen protects that absolutely crucial afferent arterial inflow valve. It's such a simple conversation, but it can literally save a patient's kidney. Finally, Section 6, High-Yield Exam Takeaways. The core knowledge. All right, for all you medical professionals, nursing students studying for boards, or just the intensely curious folks out there, here is your rapid-fire summary. The triple whammy equals an NSAID plus an ACE inhibitor or ARB plus a diuretic. The result, pre-renal acute kidney injury. The mechanism is a devastating trifecta: afferent arterial constriction, efferent arterial dilation, and an overall volume drop causing pressure to totally collapse. And your absolute top clinical priority, patient education. Teach them to reach for acetaminophen instead of NSAIDs. It is one of the most highly tested and honestly most practically life-saving pharmacology points out there. Which leaves us with this final thought to chew on. Take a quick mental inventory right now. Are these 3 hidden culprits sitting in your medicine cabinet, or maybe your patient's medicine cabinet right this very second? It is a pretty sobering thought, but armed with this knowledge, you now know exactly how to prevent the perfect storm. Thank you so much for joining me for this explainer, and keep asking questions about the hidden mechanisms in everyday medicine.